welcome all the delegates who are all the participants who are attending today's webinar. It is my pleasure to introduce Dr. Parang Sanghavi, who is a consultant radiologist at Picture This by Jankharia in Mumbai. Dr. Parang has done his fellowship in chest and MSK imaging.
Thank you so much, Dr. Aparna. And at the outset, I would like to again make this point very clear that I'm using the word cystic lung disease, not cystic interstitial lung disease or interstitial cystic lung disease. There are different terminologies in the sense that not all the cystic lung disease have to be interstitial lung diseases. There are many pure cystic lung disease. So as we go along, we'll try to understand the differentiation also and how it helps also to differentiate one entity from another. But remember this term. So try to use the word cystic lung disease wherever you are not sure. And then as we go along, I mean, we had actually collaborated earlier with MRI Online where they had to present cases for the cystic lung disease. And that time we just went to find out how many cystic lung diseases are. Then this is the list that we ended up. And still there are at least 10 more of which we didn't have the cases. So we didn't include it. But this was as many as this many cystic lung diseases. So it may appear that this is a relatively uncommon topic or something you might not feel importance at the first instance. It is fairly common. It's just that we are not used to see that very often. And it is also fairly common to misdiagnose or misinterpret them. So I hope this is visible. Now, as we go along, I'll try to give you some information, or you may ask me what information you need to make this diagnosis. So I'm scrolling from in a craniocaudal direction. So some information you only have to gather from the scan that I'm showing. I don't need to give those information. So this is the axial, right? I hope everybody can see this very well. And now this is the coronal, just to show you that what is happening. And then finally the sagittal, which is not so useful. So just stopping at some of kind of a representative image here. So what do you think? So in chat box, I hope everybody can type in chat box. So what do you think of this? Or you want some more information? Some of the information you are expected to gather from the scan that I showed. So many are going for BHD, then one more. All right. Okay. Fair enough. So what do you think of this patient? The demographic I didn't give, but this is expected. Like when it comes to cystic lung disease, and for that matter, any diffuse lung disease, you need to know the history in detail, and in history particularly what is the age and the gender of the patient. So what do you think? This is clearly a female patient, like roughly in the middle age group, right? I mean, you cannot really make out from the scan itself, but grossly looking it looks like that. So that's your first input, and then you have to think of all the cystic lung disease that you know of, and plus do you have any extra information? So first, the gross finding is this: there are multiple lung cysts, right? Then what about them? How will you characterize them? So there are multiple cysts, right? And they appear more or less rounded or oval shaped with clearly basal predominance, clear cut costophrenic angle involvement, and there are with thin imperceptible wall. That's all about your cyst that you know of cyst. And the second thing, is there any other finding? What about the background lung parenchyma? Is it absolutely normal, or is there any finding? So it's pretty much normal, right? I don't see anything else. I don't see any nodule. I don't see any ground glass, nothing else. So this is something that I meant, that we are dealing with a purely cystic lung disease without any interstitial involvement in a middle-aged female group. So that's pretty much by description. If somebody even tells you this description without even showing you the scan, you should be immediately able to tell that this is most likely to be the case of LAM or lymphangioliomyomatosis. So while some of you attempted Berthold-Dubé, that's BHD, but again, keeping in mind that this is a middle-aged female group, a patient, your first differential should always be LAM. And then other thing, there are some particular finding of BHD also that I'm going to show you a case as we go along that is not present yet. So notice how the cysts are perivascular in location, and they are pretty much rounded and oval shaped. And there is a costophrenic angle involvement also. So those, all your criteria, all the description of LAM is fulfilling in a middle-aged female group. So this is going to be a case of LAM, right? Now let's see then this other case. Okay. So that was, now again, some of the information I told you. So again, try to use those information that in this case also. So what do you think? I'm scanning from in a craniocaudal direction and then again going up. Or you may ask me question if it is not available from the scan itself. This is the coronal to show this coronal and sagittal recon are mainly to show the preponderance. What is the apical, basal, central, peripheral that helps you with this multiplanar reconstruction. So yeah, so now kind of this would be our representative images, say for example. So what do you think of this? Okay, now I think everybody got this very quickly, even without asking. Okay, so again, you attempted something on imaging, fair enough, but don't you think you have to ask me one question? So first of all, what do you think this gender of this patient is? This is clearly a female patient, right? So that is something that, of course, not going against, but that is not something that you are expecting to be if you are guessing LCH. Yes, then you need to know the history of smoking. So again, the literature says more than 90% of the cases are smoker, but that's pretty much like all the cases have to be the smoker. And or putting the other way around, to make this diagnosis, you need that information. So yes, this patient is actually female, but still she was not just actually smoker, plus also she used to have ganja and whatnot. Actually, the history, once we went into detail, she gave a kind of a list of lot of drug substances abuse. So yes, so that's why again, don't think that LCH is a has any kind of gender predilection. It is not. It is the smoking related disease, smoking related diffuse lung disease. So smoking is more important than the gender. If a female is a smoker, you should not think of anything else. You should not even think twice that this may not be LCH if everything is fitting. So that's why you need to know this detail. And like in this example, also the patient can be female. Now, what about LCH? What is the peculiarity of LCH? And especially if you want to put in contrast to the previous kind of LAM, what do you think is the difference? First of all, there are a number of cysts, right? But they are relatively small sized. That's your first difference from LAM. And plus they look quite heterogeneous, right? So what is happening is there are some cysts which look like thick walled, some cysts which look very thin walled, say for example, this cyst. And there are also, what about the background lung? Like in LAM, saw that the background lung is absolutely normal. There was no other finding, no nodules, no ground glass, nothing. Here we see that there are lots of ill-defined bronchocentric nodules, right? There are bronchocentric nodules. Some of them are kind of starting to cavitate. So that is what happens with LCH, that we'll see what the temporal evolution is. And apart from that, what is the predominance? There is clearly upper lobe or a apical predominance with actually a sparing of costophrenic angle, right? This is exactly in contradiction to the previous scan that we saw, where there was a basal predominance and the costophrenic angle were also involved. So all this putting in together, and then with the history of smoking, not the male history, but the history of smoking, then this diagnosis becomes pretty much simple and straightforward, that this is a case of, and always try to use the word PLCH, not the LCH, because Langerhans cell histiocytosis, everybody knows is a systemic disorder with actually the more common involvement of bone and everything. But here we are looking for this pulmonary Langerhans cell histiocytosis, which is actually a smoking related disorder. The other spectrum of LCH where there are bone, pituitary, etc. is involved is not actually a smoking related disorder. So that's why I use the word PLCH, or the full form is pulmonary Langerhans cell histiocytosis. And what happens here is the disease starts with a nodular form. And then as it evolves, it starts cavitate. And not all the lesions have to go through the evolution simultaneously. So that's why not just that you have this heterogeneous appearance where there are some nodules, some starting to cavitate, some thick walled cavities, and eventually thin walled cavities or the cyst. Everything can coexist together in the same segment, in the same lobe, in the same lung itself. So that's why you end up getting this heterogeneous appearance where all these different stages of the disease is simultaneously seen. So that's why you see such heterogeneous appearance. So that also helps you to make this diagnosis of PLCH. And like I again said, keep in mind that you need to have the history of smoking, right? And now let's see this. So I hope this distinction is clear, LAM versus LCH. That's a very common one and also examiner's very favorite question. Now this is one more case. I'm scrolling from in a craniocaudal direction. Again, going up, showing you in coronal. Okay, sagittal is not that important, and leaving it kind of what looks like representative images of the scan. Yeah. So what do you think here? So yes, so you want some history, right? So some of you are trying to get somebody ask me a history, fair enough. So Dr. Siddhi wants to know HIV. So you are on right direction, but do you want to know only HIV? I'm saying HIV is no. So it changes your diagnosis. I'm saying HIV is no. The patient is not a case of immunocompromised or HIV. Yes. So not just one thing, you need to know that you have to ask in real life, you have to know that all the systems, you need to know the history, because lymphocytic interstitial or LIP in the idiopathic or a primary form will be a very rare thing and a difficult diagnosis to make otherwise. But with the history that is available to you, then it becomes relatively easy. Like the patient is immunocompromised or a known case of Sjogren's or RA. So that's the another important differentiation. We are going to summarize all this at the end, and but for the time now, just remember that this is the difference from the lamb that we saw. And now the next common that cystic lung disease that we typically see here is, yes. So again, I'm going to scroll in the craniocaudal direction. What is the peculiarity? Now, of course, we have some complication also, but ignoring that, as long as the cystic lung disease is concerned. So yeah, if I were to keep here, yeah, somewhere. So now what do you think of this? Yes. So now you are going to think of Burdock Dubé, right? So first of all, so this patient is not a female. First of all, that's a male patient. There is no underlying other disorder like we discussed in the previous case. But what about the cysts? So again, the cysts are showing lower lobe predominance, right? But what is happening to them? What is the peculiarity? The shape, if you see in all the previous three cases, they were very nicely rounded or oval shaped. Here, what is happening that they are looking like a of varied heterogeneous shapes like this lentiform or a irregular elliptical, and they are also located more towards the paramediastinal margin or the along the fissures. So that is the difference. The cysts are very heterogeneous here with the again lower lobe predominance, but a very bizarre looking cyst of very different types. And then you don't have anything else that we saw in the first three cases. And remember, all the cystic lung disease, this particular complication, what is it? Is the large right pneumothorax can always happen because any of the cysts, particularly the subpleural one, can rupture in any point in time and can lead to pneumothorax. So again, in case of LAM, if you aspirate, you might even get a chylous fluid because it's a combination of morphological abnormality at the lymphatics also. So, but apart from that, this is what can happen in any cystic lung disease. The pneumothorax is a complication. So that can also come in the exam also. This can come even as a long case where there will be an entire discussion of cystic lung disease, and also you need to know this complication. So what we have seen so far is the common the 3L of this and also the other one. So what we have tried to understood is in case of LAM or the lymphangioliomyomatosis, it is typically seen in female. One more question that I forgot to ask that time is, what if the patient is male? Do you rule out LAM in male? The answer is no. Again, it's not 100% no for males, but in males, what is the condition where it can be seen? Is TS. What is TS? Tuberous sclerosis. So remember, in tuberous sclerosis, even males can have this kind of cystic lung disease, which will then be LAM, lymphangioliomyomatosis, and not necessarily that you are going to not think of it if it is a patient patient is male. The normal intervening lung. The cysts are diffuse with lower lobe predominance. Costophrenic angle is involved. And what is this? One more finding that you can clinically see is the raised VGEF-D levels. They are very sky high in this patient. So again, that is also one more important clinically also that you can check this levels also whether they are very high or not. Then we discussed about the PLCH or the pulmonary Langerhans cell histiocytosis, where we understood that the patient is likely to have smoker, need not be male, even a female smoker are at equal risk. But you have such heterogeneous appearance, right? You have nodules to cyst in a different temporal and spatial heterogeneity, from nodules to cavitation to thick walled cyst to ultimately thin walled cyst. Upper lobe predominance and costophrenic angles are hence spared here. So that's about LCH. For LIP, the lymphocytic interstitial pneumonia, typically you have the underlying etiology like HIV, Sjogren's, RA, etc. Perivascular and subpleural cyst, but as long as cysts are concerned, it may look just like LAM, but the intervening lung will not be normal. You will see some ground glass or other findings also. And finally, the Burdock-Dubé syndrome, where you see such bizarre shaped cysts like lentiform, elliptical, septate in a paramediastinal location. And what is the basic pathophysiology here? That basically these are all FLCN gene mutation for Burdock-Dubé syndrome, the fibrofolliculin gene. So to confirm this diagnosis, they have to do a genetic study to demonstrate this FLCN mutation. Again, lower lobe predominance, and these patients can also have skin lesions like angiofibroma, fibrofolliculomas, and again at increased risk for developing malignancy, the most common one being the RCC. So again, whenever you have scanned your chest scan, you also have most of the kidneys also included. So don't miss to see for this complication also, which is the RCC or other tumor that can be present. So this was about the common one, right? Now let's try and look some other cases also. So what do you think of this? So here there are not much finding. I'm going to just show you the this thing only where there is a cyst. So this patient again, you can make out. I hope that this patient looks like a teenager, right? So the patient is actually a 12 years boy and has this cyst actually kind of incidentally picked up. He actually got a X-ray done for some other purpose. So what do you think of this then? Okay, yes. So CPAM is one differential that you always should keep in mind. So again, apart from that, again there are a number of things like pneumatocyl, etc. But in that you will see some other findings also. Like typically they are the sequelae of prior infection like staphylococcus, etc. So you will see some fibrosis, some atelectasis, etc. This is just a cyst which is present. Typically it's seen in the left lung, but can be also seen in right lung like this. And then you see that there is a large cyst and there are some other clustered small cysts also elsewhere. So this is typically the type 1 CPAM that you see typically, the cystic pulmonary adenomatoid malformation. So that also is important differential you need to keep in mind, especially in young patient you are going to see. Then you can also have sometimes a cyst. You might be getting confused with the cyst. So what is this? If I show you only this, are you thinking of any cystic lung disease? The coronal also shows very well. Yes, bronchiectasis. So remember, the cysts are whatever appears like a cyst need not be always a cystic lung disease. There are mimics also, like in this case, this is actually a combination of tubular and cystic bronchiectasis. If you see the coronal also, you can demonstrate the continuity of every bronchi, right? So if you just see the axial, you might see all these are discrete and there are cysts, but it is not the case. And that's why you have this MPR, multiplanar reconstruction, where you will be able to see this continuity. So they are actually a bronchiectasis. So even if you see in the right lower lobe also, you have bronchiectasis. So this is the case of airways disease. And similarly, you can also have cysts due to other causes also, like in this case. So what do you think of this? This is the very common diagnosis that we are now used to be seeing. Now, again, we are not seeing so commonly, but what is this? Yes, so this is COVID. So remember in COVID also, especially in few of the cases, we started looking kind of the wave that many patients develop this kind of cysts also eventually. So this can also occur in case of COVID cases. The exact significances was not known that time, but again, as the healing goes on, even this COVID patients, some of them start to show a kind of cyst, mostly like a during the phase of regression. Then we have this one more entity. So this patient, I think I have the previous scan also. Yes. So now what about this? I'm scanning again in craniocaudal. Again, very little information actually that you can gather, but it looks like a very gross cystic lung disease, right? There are lots of cysts, almost the lot of parenchyma has been replaced. And I hope I have the previous scan. Yeah. Yeah. So the patient actually had previously a PET CT was done. And this is what the previous scan looked like. I think 2 or 3 years prior. So this is what it started with. So you can hardly appreciate any cyst except 1 or 2 year. But what it started with like a ground glass and opacities and nodules throughout the lungs bilaterally, and patient of course had some other systemic manifestations also. Yes, and I think some of you are getting it right now. So if you can compare the two now. So this is how it changed, right? From lungs to from the ground glass and nodules to a kind of healing with cyst formation. So this is what actually, yes, this was the case of amyloidosis, or sometimes light chain disease can also present similarly. So that also the differentiation you have to keep in mind. You again are going to think of the common things first, but again, everything that is ruled out, what we discussed earlier, then this you should at least have in your mind. Then you can go through the previous papers. Sometimes the patient might be a known case itself, or then you see for other findings, or you can at least advise because everything else has been ruled out. So now let's see some of the actual interstitial lung disease. So like I said, it need not be the cystic lung disease always interstitial, but what about this case? So you see cyst, but you see a lot of other findings also, right? Completely different to the first 4 or 5 cases that we saw where it was predominantly or a purely cystic lung disease. So what do you think of this? What would be the diagnosis? So UIP, okay, so is it a UIP pattern? First of all, UIP is a lower lobe basal predominance and subpleural. It is rather exactly the opposite, right? If I show you on coronal and sagittal, it is upper lobe predominant, quite significant bronchocentric involvement, significant ground glass, which should actually be the absent. If you remember the UIP definition, the fourth point is also there should not be other significant findings like ground glass, etc. So everything is there. So yes, this is actually what you should call what is the last bucket of the UIP classification. That's the non-IPF diagnosis. So this is a non-UIP, non-IPF pattern. In that you have the commonest two are, yes, chronic HP or the fibrotic HP and sarcoidosis. Sometimes it may be difficult to differentiate, but here you can see the ill-defined bronchocentric nodules very well. So this is what can happen. Remember, HP can have cyst, especially in a chronic and a fibrotic form. And it is in fact very common to see them, like in this case also. And remember, these are not the honeycombing. See, the cysts are quite discrete they are not stacked one upon the other. They are not like honeycombing. It is also present along the peribronchiovascular location where you expect the fibrosis also for this non-UIP pattern. So this is not honeycombing. Again, these are the cyst or a reparative cyst in this form. And with upper lobe predominance, all the signs of non-IPF diagnosis. So chronic HP also or a fibrotic HP, you need to keep in mind that they can also show cysts. Then one more ILD here. So there is some complication also. So now again going up, then in coronal. So let's try to show some of the representative image, and of course there is a complication also. So what do you think of this? So I can understand that is practically very difficult. So that's what I wanted to highlight, that practically end stage of any fibrotic ILD can start showing cysts. So that's what happened. The patient was a known case of something which was very classically seen in the previous scans almost 10 years prior that he had. So he was actually a diagnosed case of sarcoidosis. He had multiple scans, almost 12 or 13 over a period of like 10 years, started with typical nodules and the stage 1 manifestation from lymph nodes, everything. And this is how he landed up after almost, I think, 12 years. And this time the presentation was due to this complication. So again, remember the fungal wall or the aspergillomas can form in this cyst also, not just the tuberculosis, any kind of destroyed lung with cyst. And that's what had happened right now. But this was a case of sarcoid. So again, directly looking at this case, there is no way you can make this diagnosis, except that you can just suggest that this is not a UIP pattern. These are, again, I hope you can make out this. This is not honeycombing cyst. Like these are the cysts, not a honeycombing. And you have again upper lobe bronchocentric and all non-IP diagnosis. So that's at the most you can do that. Directly making a diagnosis of sarcoidosis is not possible. But again, just to show that the cyst can form in a end stage disease of practically any ILD. Yes. So what is this? Right now, typical. Yeah, UIP. Okay, fair enough. But what is about anything particular about this honeycombing? Would you like to use some adjective that has now come up, that you try to look for to make something? So this is a UIP pattern. So will you call this IPF? Yes, exuberant, right? So this is the one of the sign of CT related ILD, right? The honeycombing also, of course, you have number of other like straight edge, anterior upper lobe, everything is also fitting in, right? So this was actually a case of rheumatoid arthritis. So that's why do not use the word UIP with IPF synonymously. UIP becomes IPF only without any underlying etiology. And the earlier we used to rely on the history only, that is the patient any known case of something. But now on the imaging also, you can pick up some findings that will at least alert you that you have to suggest to for further workup for CTD. Like in this case, exuberant honeycombing and anterior upper lobe sign. And again, this patient also has this another complication, that's a pneumomediastinum this time, because one of the medial cyst must have ruptured. So technically speaking, this is not a cystic lung disease. This is, I'm trying to show the mimic. And I hope you can now make out what is honeycombing and what are the cysts in the interstitial lung disease which are not honeycombing, as we saw in the prior two cases. This is how the honeycombing looks like. There are a number of cysts of varying size and shape which are stacked one of the other with shared walls. So this is what the honeycombing looks like. The earlier cases, they all were cysts. Like in this case, these are some of the cysts. Actually, they have become confluent. But Rest of the thing is very clearly honeycombing, and we saw the signs that were present for the CT related ILD. So this also brings us to some of the mimics also. So this is what the ILD cases that can have cyst or the mimics of the cyst can look like. So the hypersensitivity pneumonitis is very commonly associated with cyst. Scleroderma is also one such entity where many a times you will see cyst. SLE. So all these are actually they have a significant vasculitic component. And any of this ILD like scleroderma, SLE with vasculitis as a component can develop cyst in any stage of during the progression. DIP also is one such entity, disformative interstitial pneumonia. And like I said, pretty much end stage disease of any of the fibrotic ILD can show them. Again, a kind of mimic actually. So what do you think of this? What is happening here? Are they cysts? Is this ILD, the fibrotic ILD, or is it a cystic ILD? What do you think of this? Yes, this is emphysema. So the patient is a smoker. You can even see this. And this is how the centrilobular and paraseptal emphysema looks like, right? So this is what is the, I hope everybody is aware of the emphysema types, the radiological types. So how do we describe this? So what do you will you call this paraseptal emphysema as? What are the two types of paraseptal emphysema? Not bullous. Bullous is something different entity. Okay, we'll see that. I have added that also. And even as long as centrilobular, there are 5 types of centrilobular emphysema, depending on the severity of involvement, and they have a direct relation or a correlation with the disease progression and the prognostication and severity. So that's why they are important. So okay, so let's do that only first. Yes. So this is what the Fleischner Society criteria again are the different type of the emphysema. So what happens is you can either have, of course, a normal. Then if there is just less than 0.5% involvement of emphysema, it's called trace centrilobular emphysema. From 0.5 to 5%, you have this mild centrilobular emphysema. If you think this emphysema is involving less than 5% of the lungs, call it mild. If it is 5 to 25%, more than 5%, you call it moderate. And then once you start seeing this kind of confluence, the centrilobular emphysema are not seen discretely, but there are large confluence of this cyst. You call it confluent emphysema. And then finally, once you have the advanced destructive form, where there is lots and lots of confluence of this emphysema plus architectural distortion and vascular distortion. So try to describe centrilobular emphysema with one of this form, whether it is trace, mild, moderate, confluent, or advanced destructive. Same way, paraseptal emphysema, you have 2 types, that is mild and substantial. So this case was substantial. In paraseptal, it's very simple. Just if you think it is just mild like this, you call it mild. If you think it is more significant, you call it substantial. Like in this case, I'm sure everybody will call this substantial paraseptal. There are such large and quite significant amount of lung is involved. But what about the centrilobular? You might call this as again a confluent centrilobular. So because there are number of centrilobular emphysematous cysts which have become confluent. So this is a confluent centrilobular and substantial paraseptal emphysema. And I think that's what pretty much we had to discuss. And now just a couple of kind of rare like things. So this is again what is happening here. So again, you have to always keep in mind this mimics also. Don't always think of cystic lung disease or other entities that we discussed for the women. You see any kind of cyst. So this is like a destroyed lung. Like this can be a post-infectious inflammatory sequelae of anything. So this is a completely destroyed fibrocystic and fibrobronchiectatic destruction of the entire left lung. Even some of the right lung also shows this sequelae. So the patient was a follow-up case of tuberculosis, and that's how he can land up. So this large cyst can be confusing also. And finally, I think the one more case, yeah. So this is something unusual. So let's see if you can get it. What do you think of this? I'm scanning in craniocaudal direction. Now going up, coronal also. So what do you think of what is happening? Okay, kind of thinking on the right direction. That's quite good actually. And what I'm showing you soft tissue also to pick up something in case you can pick up. Actually, I should have put the soft tissue properly, but there is something that is findings are present. So if in this slice, can you see anything in soft tissue? That is actually gives you the hint. And of course, the bony cage, everything doesn't look nice, right? Yes. So what is this? These are all neurofibromas. So if you see, there are a number of them on the skin surface. So if you see here also everywhere. So this patient is actually a known case of neurofibromatosis. The patient might not give you this history directly, but that's why sometimes you may need to even find out or ask, because he must be a known case and all the time, and he might not be even suspecting it to be related. So remember, in neurofibromatosis and other such some of the neurocutaneous syndrome that can develop a cystic form of cystic lung disease, and it looks like typically like this with a subpleural cyst of varying sizes with upper lobe predominance. But again, the main thing is the patient is a known case of neurofibromatosis. Then the cystic lung disease can occur in that, is what something that you should be just aware of. So I think that's what I wanted to discuss. The main important the various cystic lung disease that we come across, like the typical LAM, LCH, and LIP, and we also saw Bartok-Dubé. Then we saw the mimics like emphysema, bronchiectasis, lung restriction, other CPAM, etc. And then the interstitial lung disease, which have cyst as their manifestation. And is there any question? Then I can be happy to answer them right now. Yes.
Thank you so much, Dr. Paran, for this excellent depiction of all these cases. I think everybody wants you to explain this lung zones and emphysema again.
Yes. So this is actually the grading or the severity of the involvement. So in central lobular emphysema, you can have less than 0.5% involvement of the lung zone. That is, so okay, zone is not differently. They are just talking in general, the lung zone. Such are you asking that is it particularly related to the upper, mid, lower? No. In any this lungs, if you think the lung involvement is less than 0.5% in any of the zone, it is called trace. If any of the zone you have 0.5 to 5% zone involvement, it is called mild. It is more than 5%, it is moderate. Then from more than 5% onward till it becomes confluence, everything will become moderate. The moment you start seeing confluence of the central lobular cyst, then only you call this as a confluent emphysema. And then on top of that, if you have kind of a destructive, so these are our images actually. I think this will show it better. So this is what trace is less than 0.5. Mild is because you see somewhat here, it looks like more than 0.5, then it's mild. There it's clearly more than 0.5, so we call this as a moderate. And here anything more than this would be always moderate unless you start seeing some kind of confluence of cysts like this. That's the confluent. And then finally you have advanced destructive, where you have a large confluence cyst, plus there is a distortion of both the blood vessels as well as architectural distortion. That's what the advanced destructive is. And from paraseptal emphysema, it's just simple, mild versus substantial. Anything less than 5% will be just fine, mild. More than that, then even in different forms, like in our case, there was confluent of cyst, everything will be substantial paraseptal emphysema.
Maybe you can share that article so that everybody can.
Yes, I'll do that. So that's a Fleischmann Society article. So somebody asked GGOs in NF. Yes, though just not the cyst, even the GGO can happen in case of neurofibromatosis. That is also described. There is no particular peculiarity as long as the lung disease is concerned. It's just that you need to be aware that neurofibromatosis is associated with a cystic lung disease, and then it just becomes a description so that you don't think of anything else.
Thank you, Dr. Parang. I will now hand over to Dr. Ravinder for vote of thanks.
Dr. Parang, it was lovely to listen to you. I'm very that you have shown most of the spectrum of the cystic lung disease. Very interesting cases, and attendees were also like very actively participating. Very interesting cases. Thank you so much for the excellent lecture. I would like to thank Dr. Parna also for for organizing this lecture. And I would like to thank Clarinet team for IT support, particularly Ms. Ananya and Kana.